our friends and colleagues who are unable to join us. Thank you, Danielle, and welcome everyone to
Welcome to today's PerfectServe webinar, Clinical Integration Strategies, Considerations in a Value-Based Care World. My name is Danielle, and I will be your operator for today's call. We have just a few announcements before we begin. Please direct your attention to your computer screen as we cover the webinar platform functionality. Please note that you may need to zoom in and out from your browser to see everything. In the middle of your browser, you will see a box containing today's slides. They will advance automatically throughout the presentation. To the right of the slides, you will see a Q&A box to submit a question at any time. Your questions will be addressed during the Q&A portion at the end of the presentation. To the left of the slides, you will find a resource list containing a PDF of today's slides and a few other helpful resources. If you are on the phone line but are experiencing any technical difficulties accessing the web portion, please let us know by sending an email to webinars@perfectserve.net. At this time, I would like to turn things over to today's moderator, Heather Dorsett, Director of Marketing with PerfectServe. Heather, you may begin.
Thank you, Danielle, and welcome everyone to PerfectServe's Thought Leadership webinar series. I'll be your moderator for today's event. Before we get started, just a couple of things to note. Today's webinar is being recorded for our friends and colleagues who are unable to join us today, and we'll be able to share that with you as well after the webinar occurs. As an audience member, you are in listen-only mode. So please make use of the Q&A box to communicate with our speakers or with me today. At the conclusion of today's event, we do ask that you complete a short survey that will appear in a separate browser window. And finally, if you hear something you like today, feel free to spread the word using hashtag #PSWebcast. You will see our streaming Twitter feed located on the right of your screen under the Q&A. For those of you who may not know PerfectServe, we provide healthcare's most comprehensive and secure care team communication and collaboration platform. This webinar series is a part of our ongoing promise to drive meaningful improvement in care delivery processes. We have a fantastic webinar planned for you today. We plan to spend the majority of our time hearing from Dr. Joshua Bennett on clinical integration considerations and strategies. And that will be followed by a few minutes with PerfectServe's own Terry Hayes on how PerfectServe can support your journey to clinical integration. And we'll conclude today's webinar with a Q&A portion, so have your questions ready. And in fact, as you have questions during the webinar, go ahead and put them in the Q&A box, and I will be keeping track of those as we go. And now a little bit more about our speakers. Dr. Joshua Bennett specializes in population health, care management implementation, clinical integration network formation, Medicare shared savings program, NCQA health plans, and he is also an ACO surveyor. He also has expertise in patient-centered medical homes as an NCQA content expert and reviewer. Terry Hayes is Vice President of Professional Services here at PerfectServe. She works directly with hospital executives to understand their individual organizational needs and tailors the PerfectServe clinical communications platform to improve clinician workflow and coordination of care. She has more than 3 decades of hands-on experience in healthcare. We're so pleased to have both of you with us today. Thank you for your time. And at this time, I'll pass things over to Dr. Bennett to get us started.
Great. Thanks, Heather, and good afternoon or good morning to all of you today. We have a jam-packed information session here on clinical integration strategies, and I hope it becomes more relevant for you as we discuss it. The first thing I'd like to do is just quickly go over what we're going to do today. I think we need some background on clinical integration and how it makes sense. Talk about MACRA and Medicare shared savings programs and ACOs as sort of, again, backing up sort of what everybody, make sure we're all on the same page, and then going into really setting up a CIN, sort of the legal pros and cons of that, some tactics to maybe use to get everybody going in the same direction, what you have to sort of look out for. when you form a CIN, and then some final thoughts, and then I'll pass it to Terry at that point, and then we'll have questions at the end. So what I like to do is I like to always start out with a quote from Winston Churchill that might be appropriate. He says that you can always count on Americans to do the right thing after they've tried everything else. And we've tried a lot of different things over the last 30 or 40 years in healthcare, and we have now gotten to the point where we think that clinically integrated networks or accountable care organizations may be the thing to do. The funny thing is I just read a biography on Winston Churchill, and he actually was a very big micromanager. And so he did a lot of different things first before he found, the right thing. So it's interesting that he characterized the Americans as somebody who did the same thing he did. Although if you know anything about Churchill, he was half American anyway, because I think his mom was American. So what is the problem? What are we dealing with? And I think most of us know this already, is our costs are just going through the roof. And as a percentage of gross domestic product, you can see here on this first slide where the major healthcare programs, which include Medicare and Medicaid and CHIP program, are just taking off in terms of percentages of GDP. And we're up, we think by 2045 it'll be up in the close to 10% range at that point. And I think this is even, this is probably even more of a conservative estimate than anything else, because you can see where the lines cross sort of in 2015, and it's already over 6% almost already. So we are in a spiral that we have to try to abate somewhat, or there's not going to be any money left at the end of the day for all the different programs that we do need to have. And we are getting older by the minute, and there are days where I feel like I am getting older by the minute very quickly. But you can see there, back in 2011, we were at 48 million people that were in Medicare, which was just the beginning of the baby boomers getting in. 2010 was sort of the first year of the baby boomers. And then by about 2020 is about where, I think 2019 is where the end of the baby boomers are going to hit. So you can see there's a big gap between 15 and 20, as almost 8 million people are going to enter the rolls. And obviously the more people that we have, the more costs we're going to have. The good news is that some of the studies are starting to show that the baby boomers are trying to take care of themselves better than their parents did. With lower smoking rates, although we're still having a problem with obesity, but at least the smoking rates have been somewhat clamped down as opposed to our previous generation. And then you can see, though, what happens in the next 30 years after, 15 years after that, it really starts to accelerate, because then some of the millennia generations start hitting, and Generation X start hitting, and accelerate this even further. So we're in a deep hole in terms of trying to support the healthcare costs of our country going forward. Interesting, though, I got a couple slides here on just who's paying the most, sort of, in terms of the entire world. And you can see here on the diagnostics piece, a CAT scan of the abdomen is almost $850 here, and even at the UK it's a little bit more. But here on MRIs we're much more, we're number one there. Colonoscopy we're a little bit less. Interesting, Switzerland, if you see these next couple slides, is all at the lower end of these, at least these four countries. They're in the top four, obviously, but they're interestingly they are not number one, and they're looked at upon as they have required health care in Switzerland. So everybody within 3 months of coming in and becoming a citizen needs to have insurance. And an interesting also piece of this is, though, that anything over about $243 per month per adult is paid for by the government. So a typical family of four with 2 adults and 2 kids is probably about $650 a month, which if anybody who's paying health insurance premiums right now on their own know that that's a pretty good bargain, depending on where you are and what kind of insurance you do have. But most of their things are all covered. For example, pregnancies and other things are all covered, and including, their drugs are in that as well. You can see there that, for example, treating hepatitis C in Switzerland is half the cost of it here in the United States, and that's multifactorial. We're not going into that today, but you can just see, again, the point of these slides is that USA is number one, and this is someplace you don't want to be number one in terms of drug costs and other utilizations. And finally, the procedures themselves. And as I said before, Switzerland does have, it's basically free to have a baby in Switzerland. There's no extra premium charges or co-pays or anything else to have a baby in Switzerland, even though they're number two in the cost of that. But you can again see we are number one across the board in all of these. So we have our work cut out for us going forward. And you can see here on this slide, I just threw this in again, almost $9,500 a year back in 14 that cost us, per person. And the killer is we're not getting our bang for our buck. I mean, the men we rate 25th and 27th for women in terms of life expectancy back in 2013. Now this has gone up a little bit in terms of the age expectancy over the last couple of years, but it's still not good. For the money that we're paying, we should have much better outcomes than this. So for those of you who are considering or thinking about forming a clinically integrated network or an accountable care organization or some kind of integrated type of system, you have to ask yourselves the question, where are you on this timeline? So are you still at the point where you're paying for volume? So where you have sort of fragmented care, everything is still fee for service, you're really treating sickness rather than trying to keep people well. You have, sort of an adversarial relationship with your health insurance payers in your market. You don't have a lot of information technology and the lack of any kind of metrics, and you have a lot of duplication or waste. Versus the fact that you have the future, which is where a lot of people are going now. A lot of systems have sort of accountable care. It's coordinated across the continuum. Usually there's a integrated electronic medical record that goes across your continuum. You may even get a global payment for the entire population that you're taking care of. And you're following the triple aim, which I think most of us probably know what that is. And really working on wellness, and your partners in the healthcare system in terms of the insurance players are much more your partners rather than your adversaries. And as I said, you're sort of fully wired. So every time someone goes into your system, they're automatically, if they're registered once, they're automatically registered everywhere. And that makes it much easier for coordination of care. And you can see that sort of there's this chasm in between, and most of the people and most of the systems are sort of in that middle right now. They're sort of halfway on the jump, anywhere between the sort of the late majority and the early majority, I think, at this point. The systems that have already adapted this are way over onto the right already and are doing a lot. And there are a lot of systems in the country right now that are doing most of the things on the right-hand side of this slide. The key take-home message I think here is when you redesign your care and make it more value-based than volume, you really need to have two things in place. First, you need to have your care redesigned, making sure that you have these tools, clinical tools in place before you even take on any kind of risk. And you have to, really should be looking at patient-centered medical home installation or implementation, the clinical integration, which is, again, can you follow patients all the way through your system and making sure that they don't get lost and they don't get duplicated services. Care management, that's a term for the old case management, where someone is assigned to making sure that that person is being seen at the right time, for the right reason and by the right person. And coordinating that with your post-acute care and the EHR, MR as well, and you really measure everything that you do and follow what you're doing. But you can't do that without having some kind of new payment arrangement. So those systems that are thinking about doing all this care redesign, I've seen a lot of systems across the country that are doing it because they think it's the right thing to do, and they realize that they're not going to get the reimbursement for it right off the bat, but they do realize that once they get a new payment arrangement, that it'll be in place. And so bundled payments, episodes of care, sort of shared savings models, this whole ACO type of a concept, and actually going down to the global payment where they get the entire premium from the payer, whether it's the commercial or governmental payment, they get it all. But the two things have to go hand in hand, or you could really be in trouble financially. So that's what happens when you finally get you're taking care of an entire population rather than just individuals. I brought this slide in because, again, MACRA, the Medicare Access and CHIP Reauthorization Act, is important because no matter what you think about what's going on right now down in Washington, whether something's going to get passed to repeal Obamacare or modify it, the thing is the big point of this slide is that the SGR formula was basically replaced by MACRA, and it was done bipartisan. It was done entirely both by Democrats and Republicans. So that they are both on board with this, both sides and both parties are on board with this. And so this is going to happen no matter what's going on in terms of reimbursement or insurance. This methodology is going to continue through. And so that's another take-home message is that no matter what you think, it's going to happen. And this is a complicated-looking slide, but I can try to make it simple for you. MACRA guideline. If you look at the top sort of swim lanes, you can see where they repealed the SGR. But they kept the sort of updates in physician payments for right now, and it's going to be like 0.5% going to like 2019, and after 2019, what will happen is this first what I'll call track 1, where you get this merit-based incentive payment system called MIPS. And what will happen is that there's going to be a formula for each physician who's going to have to get a score. And based on that score, they will get either sort of a plus or minus 4 to 5 to 7 to 9% over the next 5 or 6 years. And the bottom line, the track 2 piece, is for those providers, those physicians who are in an organization such as a CIN or an ACO that basically take on risk. They're going to receive an automatic 5% bonus without doing anything in addition. And then about 0.75% will probably be increased on a yearly basis going forward after 2025. So the key thing is one of the advantages to a physician is if he participates or she participates in an ACO or a CIN, they will be exempt from doing a lot of these incentive payment sort of hoops, I'll call them, for right now. And that's going to be key because it's going to be interesting how this is all going to work. So you can see here, again, how the first year is going to be. It started actually now. First performance year is actually in 2017 for payments going down the line in 2 years. So right now, it's estimated there's almost close to 800,000 clinicians that are going to be probably eligible for this MIPS payment. They think anywhere from 31 to 90,000 are going to be exempt from MIPS and just get the bonus for the alternative payment model. And you can see down below quickly at the very high level what the MIPS are going to the MIPS hoops are going to be. So for example, 15% is going to be clinical practice improvement. So one of the things that CMS has already said is if you're a patient-centered medical home certified by like NCQA or any other organization, you'll get an automatic 15% auto credit for that. But then there's other pieces. What the quality is going to be replacing this physician quality reporting system, and the advanced care information is going to be replacing the meaningful use, and then just your costs based on your peers. The key thing about this MIPS program is it's going to be basically budget neutral. So what happens is if I, as a physician, get a 4% increase because I meet all these measures and I get a good score, somebody on the other side is going to have to lose 4%. So there's going to be a moving bar as things go through. And so for every person who gains 4%, someone's going to have to lose 4%. That's sort of a simplified way of looking at it, but it's going to be basically zero budget based. So it behooves all the physicians who are listening today is to be on the positive side of this, because if you're not, it's going to be hard to get out of the negative side hole once you're in it, because that bar will continually move because people will want to be trying to get out of the hole of not getting the bonus payments. And you can see again below the 5% is going to be automatic if you're in one of these advanced payment models. This is another fairly complicated slide. I'm not going to spend a lot of time on it, but what I want to emphasize here is those little boxes up top are the alternative payment models, the advanced alternative payment models that CMS is going to basically recognize as an APM, so automatically qualifying for the 5% bonus. So if you're in like an oncology care model or in that track 2 and 3 in the Medicare Shared Savings Program, or the Next Gen ACO project, or the Comprehensive Primary Care Plus, or actually the Comprehensive End-Stage Renal Disease Care as well. So you're in one of those four, you're going to automatically be enrolled in a in for the APM 5% bonus, which is a nice thing. But again, they have to use also a certified EMR. It has to be, with the MIPS, have to have some comparable measures as well. And again, bear more than what they're calling nominal risk for losses. So this cannot be like, well, maybe if it's year one, we can, we don't have to lose any money at all. That really CMS is looking at this as you have to be at some kind of risk for this, or it's not going to really qualify as it for an APM. And that bottom right hand is basically a little quick slideshow of a shot of in 2019 to 20. You have to have at least 25% in Medicare only, and then you can start to go to all payers, and you have to be at 50% rate, and then 75 by 2023 and on. So I don't know how. Again, so you have to increase your risk as time goes on. So it's going to be important for that CIN to basically do that. And so what are the options that the independent physicians are going to have? You can just stay in your single specialty or join a multi-specialty group. You can join the ACO or CIN, be bought by a hospital, be bought by an insurer, or just no change. And I think I'm here to tell you that no change is going to rain on your parade if you don't do anything. I think you're going to have to make a call. A lot of the older physicians may want to try to ride it out until retirement, and I think if you have a couple of years before you're going to just retire, you might be able to get away with that. But I think if you're looking at more than 4 or 5 years before you can retire, I think the no change maneuver is not going to benefit you at all. I think you're going to be in some deep trouble. Once again, you can see that the numbers are going up also by payer type in the ACOs, so you can see that mostly is commercial and Medicare are the two biggies right now moving things forward. Medicaid ACO is still sort of lagging behind in terms of the number of contracts across the country. So you can see that but they're all moving higher. So more and more people are being covered by ACOs as we speak. And you can see here's the penetration by the hospital referral region by CMS. And the darker you get, the more penetration of a ACO that you have. And you can see there's some isolated areas sort of around Denver, Portland, and middle Iowa, and up in the Northeast as well. It's got some pretty good penetration. And there's some also areas that have low penetration so far, mostly like Alabama and Arkansas and California, which is interesting. California usually leads the country with innovation in terms of healthcare, but they are being slow right now to join because one is they've already had a lot of, and those of you who are maybe in California know you have a lot of independent practice associations which are driving a lot of the care already. So there's probably no need for them to really to join an ACO necessarily. And as I mentioned sort of a little bit before, is CMS is going to really be tracking quality. This is a big item on their agenda, and they're going to make it transparent as well. So the ACOs that are going to be out there are going to get quality scores. In fact, there's thresholds that they have to meet to basically get into the so-called shared savings money. And then a lot of these quality scores are going to be based on the HCAHPS and the CAP scoring, and also some of the CMS measures that they have as well. So it's going to be very important to, if you think about this and build a CIN or an ACO, you have to keep the quality probably foremost in your mind as well. So I've come up with a slide here on what you need to think about if you're a health system thinking about how this is going to work. So you have some options. You can approach population management different ways. You can form the CIN or an ACO, or even just start with patient-centered medical home implementation of your network. Or some hospital systems are actually developing health plans. So they're actually taking on risk. Developing, most of them are starting as Medicare Advantage plans, but I've seen some other ones take on commercial risk as well. You have to keep in mind that you have to deliver high quality, superior value and care. So quality at a reasonable cost, because as you move this into not only from CMS standpoint, but from a standpoint of the employers, you have to maintain quality and make sure that as you do that, you align the entire continuum of care, and make sure that you have sort of similar metrics for what I say both groups, the hospital side and the outpatient side. Need to have some of the same metrics so everybody's rowing the same direction. And also shared incentives as well, making sure that you deliver the right care and you incentivize the pieces of that care at the end of the day. So, for example, if you have a bundled payment system for knee replacement, you don't not only incentivize the orthopedist, but probably the physical therapist, and also even maybe some of the home health aides as well, who may be helping get that patient back to normal. And the other thing you have to keep in mind is that clinical performance as well, making sure that you have standardized clinical protocols, so the best practices that are agreed to in your region, and that the system adopts those that the physicians feel are the best. Making sure your handoffs and all your coordination is pretty tight, so you don't lose patients within the system. Making sure you set targets, making sure you have outcome performance measures as well that are done, and keeping your eye on the readmission rates, which is going to be a big issue. And finally, engaging the patient, which I think is going to be one of the hardest things we have to do going forward. The patients who are very cooperative, that's a no-brainer, but those 4 to 5 or 6% who are probably responsible for 30 or 40% of the care and who just are not cooperating, we're going to have to figure out systems and mechanisms by which we engage these patients. If we don't, we're going to be in trouble. This is a slide that in my past life as a consultant I've used, where we basically score a health system and on these 8 pieces. So do you have focused leadership? Is there care coordination? Is there a robust PCP network? Is there clear communication? Very, very important. Making sure that there's transparency and everybody knows what's going on at all times, I think is very, very important. The data and analytics is without saying, has got to be done. You can only manage what you measure. Making sure, as I said before, your aligned compensation is there and your patient engagement is starting to occur. And then making sure, I think the key thing is it's got to be led by physicians. Every place that I've been across the country in the last 5 years, any place that starts a CIN or an ACO and does not have physicians involved is either failing or not doing very well. There really is a key piece of this as well, as making sure that your physicians are involved. And so a quick slide on Medicare Shared Savings Program. Again, it's focused just on the engaging those Medicare fee-for-service patients only, so they cannot be in the Medicare Advantage plan already. But it does, once you participate, a network gets automatic sort of ACO status and significant legal waivers as well with that. So it does develop, an ACO does allow the health system to basically serve another patient population and be rewarded for the effort. So, for example, they can take the Medicare population and then put that right into an ACO and keep it separate from your commercial or Medicaid book of business if you need to. Partnering with other health systems does occur. I've seen it across the country where several systems do get together, form sort of a mega ACO and cooperates. And that way they can pool resources without having to actually merge or do anything else that's legal, but keeps it all under an ACO. Some of the barriers that you can have, if you don't have at least 5,000 lives in your catchment area, you will not be able to get a Medicare Shared Savings Program contract. It's on an annual basis. It usually is right about now. It's about the middle of the year that you can apply for it. You get a 3-year contract term, and you have to stay in that track for the duration of that contract. So those are sort of the hurdles that you might have. So let's move a little bit now toward the broader subject of a clinically integrated network, and I'm not going to read all these different definitions, but again, the regulatory is a big one. So it needs to meet certain criteria, which I'll go through in a minute, so that you can negotiate contracts directly with other payers on sort of a single signature basis. So this makes it very much easy for you to have you as a health system to have a cadre of physicians and inpatient and other facilities that you can all do sort of single signature basis, which is really nice. And the bottom is just the CIN it's a platform. It's a legal platform that allow both the physicians and hospitals to basically prosper as this whole system evolves. So you can basically contract with payers for IT and care management resources. You can get management fees. I've seen a lot of different ACOs that get a fee from certain payers who are, basically delegate their care management functions to the ACO and allow them to basically get a fee for it. So they can either support a salary of a care manager, or the actual health plan can actually, quote, buy their own care managers and place them in some of the patient-centered medical homes, for example. And again, work up deals where you can get this pay for performance. So making sure that if you have quality targets that you need to hit, for example, percentage of mammograms, or patients who are in a like diabetes and need to have their diabetic parameters checked. Things like that can be very helpful. And this is just what a structure would look like. You can see the CINs in the middle, but you have the network and the hospital, post-acute services, all around behavioral health. All these on the outside become sort of what I'll call cost centers now, where a hospital used to drive the revenue. Now it's going to drive the cost. And so it behooves the CIN to basically adopt a lot more health plan type skill sets so that the hospital beds do not stay occupied, and people stay more out in the outpatient side of the system. And you can see, again, there's IT, there's care management, and health, and the financial that has to be considered as well. This is another way to look at the organizational model. So think about the CIN being in the middle. You have independent physicians on the left and the health system on the right. You can also have employed medical groups that are underneath employed by the health system, but can also be part of the CIN. And also, if you have ambulatory facilities such as like a surgery center or other type of centers, you can also put them in and include them into the CIN. You can negotiate with outside entities if you like. So your upper right-hand corner is the payers. It can be basically self-pay. It can be employers, CMS. Any of these can do that. And then on the return side, you can get care management fees and shared savings out of it as well. Interesting piece of this as well, that you also employ care managers down on the bottom, and you can work on your claims analytics and IT services. Sometimes if you're partnering with a health plan, they will provide a lot of the claims and analytics for you. But you can also then contract with other outside entities, for example, SNFs, skilled nursing facilities, or outpatient acute rehab facilities. You can contract with them. Not many ACOs have put them into the system unless they already own them through the health system, but you can contract with them. And there's been all sorts of interesting ways that they've been contracted with. For example, guaranteed beds. So an ACO is guaranteed at least 2 beds no matter what time of the day, month, year it is, and they sort of have them on standby as they need to, and they're contracted to do that. Or that they have an exclusive, we will admit all our patients to this nursing home and do it that way. So there's different ways to skin this cat. So I'm not a lawyer, I'll be the first to tell you that, but here's some of the requirements for a CIN. And you can see here, you really need to have a program that evaluates and modifies practice patterns. So you really need to have acceptance by your participants of standard clinical guidelines. So making sure that we all treat hypertension in a stepwise fashion, maybe not totally agreeing on exactly the medications to use, but at least a broad outline that's clinically accepted by all the providers. And also making sure that there's some kind of cooperation that will control cost and improve quality. So to that end, you need to make sure that you have your participants are all subject to potential termination if they do not follow clinical guidelines, or they have other reasons to, if you have a policy that basically states here's what you have to meet, credentialing criteria, quality criteria, and if you don't meet those, you have to have that capability to basically terminate providers. And that's probably the first thing that the FTC will look for when you do apply for this sort of antitrust protection. They do apply the rule of reason, FTC does, and really if it looks like you're trying to integrate providers and not trying to just collude together, they will make sure that they will say, okay, fine, this is reasonable to do this. And again, the initiatives and the goals of the program really need to show that you want to improve the healthcare cost and efficiencies. And finally, just again, organize it to achieve collaboration among physicians and the hospitals. So you have to show that there is some kind of effort to coordinate care and collaborate among all the different participants in that care. And again, this is just another way to look at the governance of this. So the CIN's in the middle. Your board of managers most of the time is mostly physicians. But if you do this with a health system, there are some obviously health system representatives on this board of managers, but the majority are physicians. And every successful ACO or CIN that I've seen so far has a majority of physicians on this board. And that board is responsible for all the activities. Generally what happens is they form 3 different committees, a finance, a quality, an IT, and a credentialing committee. And you might even have utilization and quality in the middle one. Once again, all led by physicians, and they do the things you can read below there, what their duties are. So what can you do legally? Again, not being a lawyer, but you can read here and you can see what it is. So you can basically make sure that you have this integration, maintain the infrastructure to operate the whole system, make sure you have that network of providers, and you can contract on behalf. But you cannot be a licensed healthcare provider. You cannot control any practice of medicine or own anybody's practice. Now you get away from that if you have a hospital-employed system, because the hospital then passes them over to the ACO. And you can't dictate any kind of internal financial or other decisions on a provider's practice. And so the value for a physician is that it will be physician-led and professionally managed. You can really enter a lot more different payment models than potentially you could do as a single provider. You have much more leverage that way. You do have additional resources that are available, so there may be funding for care managers that you can place in your PCP office. I've seen a couple of ACOs actually support getting everybody on the same EMR, and so they provide stipends to those physicians who aren't on the same EMR, and so they can provide some stipends to help that and make sure everybody is on the same page, so you can report quality and macro all at once as an entity. And that goes to this robust IT platform and capability at the bottom. So questions to ask yourself are you culturally ready for building a CIN? Does the senior leadership have the clear vision and strategy to do this? Does the majority of the medical staff want to do this? Are you being forced as a healthcare system to do it, or are you being proactive? Do you have already a strong care management system in place? Specialists willing to be reimbursed not to do procedures and decrease admissions? Do you have staff with health plan skill sets like I talked before? Instead of saying we need to fill the beds, we look at admissions per 1,000 and making sure that we do not have heads on bed. An empty hospital in this case is a good hospital to have. And making sure you have tactics to decrease your readmission rates, making sure the EMR is all coordinated. And again, is your healthcare system a leader or a follower? Are they waiting until everybody gets this done, or they want to be out there in front, or are they somewhere placed in the middle? So those are questions you have to ask yourself. And again, you need to have that commitment to long-term success and investment. This is not build it in 2 weeks or 3 weeks or 2 months or 3 months. You got to be in this for the long haul in terms of years. This takes time to build. Most CINs can be formed legally pretty quickly, but it takes a good 18 to 24 months to really start putting the resources into it and making sure that it works on day to day. And you do need those strong physician leaders, those champions who really can lead this formation process and get their peers to participate in as well. It's really important. There has to be that commitment up front for education, not only with the physicians, because you have to have a lot of physicians don't understand how this works, and they're almost surprised when you say, you guys are running this. And they take ownership, and it really does help them buy into the whole proposition, which really helps. And finally, committing that investment of time and capital is really necessary, and you really have to do it correctly. You cannot do this sort of on the half-baked type of maneuver. You have to do this. You got to be all in, or it's just not going to work. And you really then have to know, is there availability of value-based payment contracts once you form it, or you're going to be getting this up and running, doing some dry runs first, and then work on getting a contract. Here are some mistakes that we've seen across the country. Do not have you have a lack of strong physician leadership. No one really wants to do anything, so it just doesn't work when everybody's working off the corner of their desk, for example. And again, that's the same thing. You need people, both physicians and non-physicians at the beginning, to really put a lot of time and attention into this, or it will not work. Again, the formation process needs to have that physician input. And you can't just engineer it from the top down. You get a couple health system executives say, hey, this is the latest thing we got to do, and the physicians aren't on board. Or you get the physician leadership or the executive leadership that says, this sounds good, we're not going to spend a whole lot of money to do this. This costs some money. This is not like a couple $1,000s here or there. This is usually, to make this successful for a good-sized health system, it's in the millions of dollars, and you have to be able to devote that and swallow that you're going to probably just spend that money because it costs that much to get it done. Turf battles that occur. You need that talent basically managing sort of a lot of different day-to-day activities. That health system skill set that you need to get the right people doing the right thing, making sure you do hire some good expert counsel to make this happen, or you're going to wind up in some problems. You do a poor physician recruitment, so that's the other issue that you may have as well. And there's no payer contracts. So really quickly, these are the 5 areas that you have as an infrastructure between clinical performance, network operations, analytics, contract and financing, and development. And you can see the different functions that go on below that as well. This is, again, a process timeline. You can see here that the first 3 months you sort of spend just getting the education done, getting counsel in place, forming a transitional work group, and then over the next 9 to 15 to 18 months, you form it legally, you form your committees, and then you start overseeing and build these clinical and financial and credentialing processes. And then you go into operation. So nothing's certain until the healthcare system bill dies or passes, but I still think macro is moving ahead. They're not, CINs and ACOs are not for everybody. You need some kind of an alignment, though, to make this happen for future survival of the health system. Once again, the closer I think a health system can get to the actual premium, the more control and financial success you're going to have. And finally, remember, it's always about the patients, their care, financial stability, and their health and wellness. And I'll leave you with a final thought from Thomas Edison. Opportunity is missed by most people because it's dressed in overalls and looks like work. And forming a CIN is a lot of work, and it's not easy. But if you make it successful, you can make it very financially and clinically and quality-wise very successful. So with that, I'm going to switch it over to Terry Hayes, and I'll let Terry take over and talk about how communications really plays a good part and a big role in this plan.
Thank you, Dr. Bennett, and thank you for that very informative presentation. I learned a few things along the way. And I'd like to take just a couple of minutes to talk to you about the role of secure communications and care team collaboration in your overall clinical integration plan. You wouldn't be far off course if your first thought was to rely heavily on your EHR to support your clinical integration strategy. And while the EHR is a valuable tool for sharing patient information within hospital systems and broader care networks, it lacks a fundamental quality that bridges gaps between the old meaningful use criteria and true clinical integration. Moving a patient safely through the admission, treatment, discharge, and post-acute care processes requires a tremendous amount of coordination, good communication, and a sound clinical integration strategy. The tools you use to support that communication and collaboration will play an important role in your overall success. PerfectServe unites physicians, nurses, and other care team members across all care settings. We're effective because PerfectServe enables communication-driven workflows that facilitate timely care team collaboration. PerfectServe is able to help physicians navigate and ease the transition to value-based payments by protecting their time through ensuring that only communications that are personally relevant and require their action are received. They're not bombarded with erroneous phone calls from colleagues and care team members. And further, PerfectServe is able to eliminate unnecessary interruptions, lost and delayed messages, facilitates more direct communication and better collaboration among physician colleagues and team-based care members. It enables more efficient care coordination under alternate episode-based payment models, and enhances the quality of care by enabling your physicians to speed time to treatment. Importantly, PerfectServe manifests proven high physician adoption because of these values, leading to enhanced physician satisfaction. Other outcomes include expedited direct consults, speeding time to treatment, reduction in care delays, and reduced referral leakage and revenue loss, and improved patient flow. And many of you may have seen this slide before, but with every communication that occurs, PerfectServe is able to analyze a combination of real-time situational variables to ensure that the communication is delivered to the right physician or nurse or other care team member, the one who is able to respond at that particular moment in time. This capability eliminates the need to search and struggle to find this information only to end up calling the wrong person. By doing this, PerfectServe facilitates communication-driven workflows that enable time-sensitive care delivery. Furthermore, PerfectServe's single cloud-based architecture extends dynamic intelligent routing across the entire provider ecosystem to facilitate the constant struggle that people seem to have with the collaboration across those geographic and organizational barriers. In this transition to value-based care and payment models, PerfectServe is able to serve as the vehicle for improved collaboration and care coordination under alternate episode-based payment models such as bundle payments and MACRA. PerfectServe uniquely provides communication management functionality for all employed, affiliated, and even private physician groups. These capabilities include these listed on this slide that I will let you read for yourself. But the important thing is that the tighter that and the more secure that communication and collaboration is, the more patient-centric it becomes, and it really enables that collaboration across all of those care providers. In Dr. Bennett's presentation, he outlined some of the key components of the clinically integrated network infrastructure. And PerfectServe, of course, is uniquely positioned to support the network operations infrastructure requirement while providing value in the other CIN infrastructure dimensions. Care management requires patient-centered interdisciplinary collaboration. Case managers, call centers, acute and ambulatory care providers strive to streamline communications, improving patient transitions that span that care continuum. The ability to communicate with the correct provider or care team member in a timely and both a secure manner is of paramount importance in optimal care delivery. Audit capabilities relative to communications and response times, or even the ability to use a mobile device for point-of-care charge capture, are additional features that support the infrastructure and operational needs of a clinically integrated network. And lastly, as healthcare evolves, solutions must keep pace with the inherent demands that provision of the cost-effective quality care that we all strive to deliver imposes. PerfectServe seeks to continually enable the communication-driven workflows that facilitate timely care team collaboration You've probably heard me say that sentence a time or two because that is the PerfectServe vision. And to that end, our product capabilities continue to evolve as dynamically as the healthcare ecosystem in which we work. So thank you for your time today and attention, and thank you, Dr. Bennett. I'm going to pass this back to Heather for questions that you may have. Heather?
Great. Thank you. Thank you both, Dr. Bennett and Terry. We appreciate that very informative presentation. I think I learned a few things myself. With our remaining time, we want to answer any questions that our audience may have. I do have a few questions here, but remember, if you have any questions for either Dr. Bennett or Terry, to go ahead and put those in the Q&A box, and we can answer those here in the last few minutes that we have today. So first up, a question for Dr. Bennett. You mentioned this a little bit in your presentation, but how are you seeing physician groups opting to do nothing and accept penalties? Is this commonplace? How often are you seeing that happen?
Well, right now, there are no penalties right this second because it's not going to take effect for another 2 years. But I think I've seen some healthcare systems that think that integration is sort of a fad and have elected to do nothing, and they've gotten behind the 8 ball in their market and wind up becoming a follower rather than a leader. So I've seen some health systems, choose not to do anything. I've seen a couple of physician groups who have expressed the interest of not doing anything, and it's been mostly the specialists, quite frankly, that, again, not to offend any specialists out there, but I'm just saying that mostly specialists have opted to say, well, we don't really need we don't care if we get a penalty or not at this point. But they don't know until what they don't know. So I think they're going to find out in a couple of years. So it's sort of a nebulous answer. I'm sorry I can't give you more specific, but there are some that are choosing not to do anything right now because it's too far away.
Got it. Thank you for that. Next question is also for you, Dr. Bennett. What do you think physician groups are looking for relative to participating in a network?
I think one of the things they're looking for is financial stability. I think they want to be able to maintain their present incomes and salaries, and I think they're looking for a system or a network that can help them guarantee that. And that, plus I think they're also, some of them are joining because of the potential infrastructure advantages. They might be able to get a care or case manager in their office, or the health system may help them, if they're a CIN, it may help them, buy a electronic medical record that might hook up to the hospital. And so they're looking for a couple different things like that.
Okay, so we have a follow-up question to your answer on that. Does this mean the end of independent physician practices?
Oh, great question. No, it doesn't. In fact, I think the interesting thing is those physicians who are now independent can sort of remain so by potentially joining like a CIN if there's one forming in their market, because I think they can then remain independent, have significant input into the governance and the running of the CIN, and yet maintain their independence, which I think is a real plus. In fact, that's one of the big selling points that I've seen across the country, that the CINs approach a lot of these independent physicians and say that, there's a minimal buy-in, and they usually make it very nominal, like a $500 membership fee or something like that. But then they can get some bargaining power through the CIN in terms of potential, better rates, and so they have that opportunity to be able to do that. So I think that's actually a real big selling point on that. So I don't see the total dissolution of independent physicians. I think it's more of an individual basis. I've seen a lot of, for example, cardiologists now across the country who believe that they probably should join or get bought by a health plan because of their income has been sort of dwindling. So I think a lot of, for example, cardiologists are joining health systems just so they can maintain a salary structure. So it's interesting how that seems to be driving a lot of the decisions.
Great, thank you. All right, one more question for Dr. Bennett, and then I have a question for Terry next up. Dr. Bennett, what seem to be the largest hurdles systems face in attempting to formulate a CIN?
I think the largest hurdle is the financial one. I think a lot of health systems right now are doing okay, and I'll put that in quotes. Some are very successful, doing very well. Some are just barely making any kind of margin. And so to be able to sit down and devote, a couple $1 million or more to something that's still out there in the early stages is, I think, a very tough barrier and tough hurdle to meet. And I think it takes some convincing on the part of the hospital senior leadership, and a lot of times even the physicians are wondering, should we do something like this? So I think the finances are probably the biggest barrier at this point.
Got it. Thank you. Terry, this question is for you related to PerfectServe. What is PerfectServe? Is it an EHR, a messaging tool, an on-call system? Can you give us a little bit more information about what exactly PerfectServe does?
Oh, sure, Heather. So PerfectServe is a communications and collaboration platform that includes functionality such as secure messaging and call schedule management. But it's a platform in which you can communicate via secure text or phone call, patient-centric communications in real time. The additional feature is a dynamic intelligent routing, which routes that message to the correct provider covering for that patient at any point in time. And it streamlines communication across the continuum.
Great, thank you. So we have a couple more minutes here, but before we, I think I have one more question. Before we get to that, we have a question for our audience. Would you we have a polling question here that'll come up in just a second here. Would you like any additional information after today's webinar? And while you're submitting your answer to that, I have one more question here for Dr. Bennett. What have you seen as the strongest methods for soliciting input from physicians relative to CIN governance?
I think this is sort of multifactorial. So I think the first thing is sort of an education program. So I've seen, and I've been actually part of consulting teams that have gone in and helped educate the physicians on what exactly population health is, what's clinical integration, how does the CIN work, sort of almost a lot of the slides that I just showed today. And so there's an educational process that needs to happen to get some of the physicians realizing that there is an issue and there's something to be said for addressing it. It's interesting when we've given presentations to watch this sort of the eyes sort of light up a little bit, saying, "Oh, we got to get going here. We're if we don't do something now in 19, we're going to be financially in trouble." So I think that's one of the big things. I think another piece of this is also getting a physician champion or champions who understand what this is all about. And I think the CINs that have gotten formed probably more quickly have been those that have had multiple physician champions pushing this, saying this is what we have to do, and along with a health system senior leadership that also agrees with them, and they're all on the same page. And then finally realizing that the physicians are running this, are going to run this. In a successful CIN, the physicians will run this and have majority voting rights and really run this. And so it becomes, as I said, I think earlier, it becomes theirs to basically run and govern. And that makes a big deal difference when you have that sort of accountability as well.
Excellent. Thank you. Well, that wraps up our Q&A portion for today's webinar. Before we part ways, I do want to share with you the next two webinars in our Thought Leadership series. You'll see here on the screen, we have one coming up on August 10th in collaboration with the Advisory Board on high-performance medical groups, and then another one coming up on September 28th on care transition strategies to improve readmissions. And there are CEUs offered for that one. for nursing and case managers. So be on the lookout for invitations for those. And to wrap up, I want to say a huge thank you to Dr. Bennett and Terry Hayes for a fantastic presentation today. And thank you to our audience for joining us. Please do take a moment to complete the short survey that will appear in a browser window and tell us how we did. And have a great afternoon. Thank you.
Thank you, ladies and gentlemen. This concludes today's webinar. Thank you for participating. You may now disconnect. Speakers, please stand by for your post-conference.